Hi, this is Andrea Kane, and I'm here with you for HIT 445 Quality Management. This is the last lecture video for week 2. It is on Chapter 9, Improving the Provision of Care, Treatment, and Services. So our learning objectives are talk about the 4 core processes or elements in care, treatment, and services, common means by which healthcare organizations monitor and improve quality of these, and talk about national patient safety goals, which I think we've talked about before, but for the fun of it, we'll go back through them again. We will talk about roles that clinical practice guidelines and evidence-based medicine play in standardizing patient care, and talk about how patient preferences impact patient-centered care and outcomes. Although we will be going back for Chapter 7, which also focuses on patient satisfaction. So some of this information we'll go over a little bit early, but it'll dovetail back when we cover Chapter 7. So what are those 4 core processes? They are assessing the patient's needs, planning care, treatment, and services, providing care, treatment, and services, and coordinating care, treatment, and services. If you want to follow along in your book, the start of the chapter is page 154. And figure 9.1, patient care process cycle, is on page 155, and that gives you a good idea of how this works in terms of being a cycle. What happens? When is there patient and family input? When is there colleague input? When there's their physician input? And how does that all bring about the point at which the care is completed? So I'm going to refer you to your book because it does a pretty good job on pages 155 through 159 of going through each of those core process steps. Where I'd like to pick up is, and there's that figure that I just mentioned that was on page 155. And then this is going to go through all of those individual steps. So I'll show you the screen so that if you want to pause it, you can. But this is all in your book. Although I'm going to stop at this point, actually. I'm now up to page 160, conducting patient care outcomes review. I thought this was a different slide, my apologies. Let's talk about optimizing patient care, steps to success. How do we optimize patient care? What are we looking for? Well, the first thing is you want to conduct patient care outcomes review. How was the patient's stay? How did the patient leave us better, the same, or worse? How can we make sure the patient, this patient, other patients have the safest and highest quality of care? What are some issues that might be related to medical necessity for treatment and appropriateness of care? That's all here at step 1. So the first thing is you look at the outcomes. And you look at it for every patient ideally, but especially anything that you had issues with. And it talks here about accountable care organizations and different other areas that have developed metrics for following core measure sets based on claims data. So you're looking at the outcomes. You're looking at anything that was sort of an outlier that had issues. Are you, or not only issues, but outliers? What was very different about this stay when it came to treatment or appropriateness of care? Were there any medical necessity issues? Then you move on to step 2, and this is at the bottom of page 160, where you evaluate the organization's use of seclusion, restraints, and protective devices. That makes sure, because there are so many rules, whether you're talking accreditation rules or federal regulations that govern the use of seclusion, restraint, and protective devices. You have to make sure constantly that that documentation is completed at or near the time of event, and that it has all of the itty-bitty tiny major requirements that go with those. So that's another area you look at. So the first area you're looking at are patient outcomes. Then you're looking at, did we use seclusion, restraint, or a protective device on this patient? And if we did, what is the documentation? What is the outcome? Step 3 is looking at Lab services and blood products. Did we make sure, and this is where you get into CLIA. You may have heard of CLIA. It's Clinical Laboratory Improvement Amendments with the CDC that govern labs. More and more hospitals choose to be CLIA certified rather than Joint Commission certified when it comes to lab. But anyway, there are all these standards that are related to lab equipment, the training of people who use this equipment, how frequently the equipment is calibrated, recalibrated, tested, just all sorts of things along that line, and how specimens are handled, how they are labeled, how they are brought to the lab, what happens to them inside the lab, how are they disposed of, all of that. And not only the use of the lab equipment, but they actually look at the training of the people who use that lab equipment. And then, of course, they're looking for blood products. How are those managed? Are you ending up disposing of units of blood unused? Did you have any transfusion reactions? Did you have any errors with matching, cross-matching, things like that? Temperatures of where blood is stored, of the equipment that stores the blood. Are those temperatures being checked and maintained 24/7, 365, all of that? And then you look at medication systems and processes, and that's where you get into the pharmacy, and you're talking about, oh, I guess they don't give us anything there on that slide, but you're talking about how they're handling controlled substances, how medications are wasted, how you're making sure that medication is stored appropriately. What happens if the patient brings in meds from home, if they're an observation patient and they don't want to pay for hospital rates of meds, and so they bring in their own meds. If they're an observation patient, they can do that. But where are they kept? How are they stored? How are they labeled? How are they dispensed? All these types of things need to be assessed. Then you go on to policies, procedures, and documentation review, making sure that policies are current, procedures are still up to date, that you haven't had any change in technology or in software or in who carries out a procedure, making sure that the documentation is being kept and maintained, accurate, timely, who's making edits, when are they making edits, do you have audit trails in place, who's accessing the data, all of these types of things. And then you've got the standards of care and care pathways. And that's where you're going in and you're saying, okay, we have a clinical pathway for all COPD patients. And so are we utilizing that? And how is that working out? Those are based on patient diagnoses. And that is now up to page 163 in your book. So some ongoing developments. National patient safety goals have been around for what seems to me ages. 15 years maybe. Maybe longer than that. But they are across every hospital. They are Joint Commission based, but pretty much everyone uses them, whether they're Joint Commission or not. And those are the National Patient Safety Goals. They list them for you in your book, figure 9.3 on page 164. They give you the 2018 version, but I'd encourage you to go out and look for the 2021 version. That should be published by now. But they're like patient identification. You need to use 2 ways to identify patients, improve staff communication, use medicine safely, use alarms safely, prevent infection, identify patient safety risks, prevent mistakes in surgery, prevent patients from falling. And that one focuses more on long-term care, but acute care hospitals are also penalized for patients who fall and have some kind of injury, significant injury like a fracture or a hematoma. And then prevent bed sores is also long-term care, but that's also acute care hospitals as well with decubitus ulcers. If a patient comes in and they do not have a stage 3 or stage 4 ulcer and they develop a stage 3 or stage 4 ulcer, pressure ulcer while they're in the hospital is held responsible for that. So if you have somebody who comes in with a stage 2 pressure ulcer into an acute care hospital, they have got to be on it to make sure it doesn't advance to stage 3, because if they do, it becomes a HAC, a healthcare acquired condition, and they can be penalized for that. So even though it says here that patient falls and patient bed sores are long-term care, they also very much apply to hospitals, acute care hospitals, because they fall into the HAC program. Oh, sorry. National Standardization of Patient Care Processes. This is on the bottom of page 164, and where they're talking about clinical guidelines and how to care for a patient based on their diagnosis and standardize that care. They found what works best in most patients, and that's that through evidence-based medicine, and that's what they try and implement across all hospitals. And then patient-centered care initiatives. This is where, if you look at figure 9.5 on page 165, the principles of patient-centered care, this is respect for patients' values, preferences, expressed needs, and making sure that that's coordinated and integrated in their care. Providing information, communication, and education, as well as physical comfort, emotional support, alleviation of fear and anxiety, and involving family and friends as the patient wishes. And then continuity and transition, making sure they have access to care. It used to be that patients weren't the center of care. And so over time, it has really shifted in healthcare across the country and across, well, I don't want to say across the world, but across the country, to really be more patient-centered. What does the patient need? What does the patient want? And respecting those things and providing those along the way. And then long-term care and home health care monitoring. There have been lots of opportunities for improvement there. In long-term care, the MDS, minimum data set, brought in a lot of opportunities to identify improvement initiatives. And home health, now that they've got some standardized things that they have to report as well, that's where you're going to see all of this continue to emphasize looking at these data sets, and from there identifying areas that need improvement and focusing on those. So you have that. And then the next couple of pages, 167, 168, 169, talk about, oh, and 170, quality indicator profiles, how because they're collecting this data and reporting it, they can see how they stack up against others and whether or not it's something that they need to improve. And we talked about national patient safety goals. So all of those are there. And universal protocol for surgery. This is now mandated in so many places. Definitely Joint Commission accreditation. They actually go into the OR. When you have a Joint Commission survey on site, they go into the OR. They scrub, they gown, they dress it all up, and they go in and they actually stand inside the OR and they are watching to make sure that there is a pre-procedure verification process before the surgery gets started, that the procedure site is marked, and that the timeout is performed. So the pre-procedure verification process, that's first. That's where they go in, make sure they have the right patient. And this is when the patient's still awake. They ask the patient, okay, who are you? What's your name? What's your date of birth? What are you here for? And hearing the patient's words to make sure they understand which procedure they're here for. Then they make sure that this procedure site has been marked. Sometimes the marking happens earlier, like a day or two ahead of time. The physician will use a Sharpie permanent marker and actually mark the site. Sometimes the procedure site is not required to be marked. It's very clear what it is, and it doesn't have to have an exact X on the spot. But the timeout has to be done. The timeout, going back to the mark the procedure site, that's really about laterality. If you're going to have a procedure on your right wrist, you do not want to wake up in the PACU and have had surgery on your left wrist. So typically the orthopedic surgeon who's going to do your carpal tunnel release will put an X on your right wrist exactly where they're planning to do the surgery. And it's the same for other things. The time out before the procedure, that happens when the patient is brought into the OR room itself and everybody stops. The patient's probably out and under, but this is where the anesthesiologist has to stop and listen and participate. The surgeon has to stop, listen, and participate. All of the OR staff have to stop, listen, and participate. Everyone does. There's a designated person that reads out, this is this patient, and they verify the wristband. This is the procedure we're going to do. The surgeon verifies that. This is the procedure site we're going to go for. Yes, they verify it's been marked, or if it hasn't been marked, they all agree this is the procedure site, this is the patient, this is what they're going to be doing at that site. Everyone has to agree before a scalpel gets picked up, and they all have to be quiet and listen. If your anesthesiologist is over fiddling with equipment and ignoring the whole process, you will get cited by Joint Commission. You will. I have worked for organizations where that has happened. I have seen them do the same thing with a surgeon. If the surgeon's off doing something else or is standing there tapping his foot, Joint Commission will address that. Everyone has to stop and be present and listen and be a part of this. Standardization of care processes, we talked through this. Making sure that it's patient-centered, yes. Again, asking a patient their preferred name, if they want the lights dimmed. One patient preference that I have been a patient before that always drove me crazy is I asked my nurse to please keep my door closed. I wanted privacy. Please keep my door closed. I cannot tell you how many times I had to say to everyone who came in, please close my door when you leave. Please close my door when you leave. Please close my door when you leave. It was my patient preference, and it got a little bit frustrating that they didn't seem to understand that. But so you want to ask a patient, and then you want not just ask them, but actually follow through on it. And then telehealth, patients are treated where they are and when they need the care, and that's through electronic transmission. I think we're all really familiar with telehealth after COVID last year. We talked about MDS and OASIS. I've forgotten what that one was. OASIS is home health. Those are the data sets that they have to submit the information to the government. All right, so that is it for Chapter 9. Next week is Week 3, and we will be looking at Chapters 10 and 12 through 13. Have a fabulous week. Take care.